Steve, in reference to fasting, we talked about fasting this morning. Now, I remember reading a blog you wrote on, I think it was the Virta site about fasting. Give us a quick overview of the Phinney view of fasting.
What you mean quick, Doctor?
Jason Fung's out of the room, so...
Jason and I have discussed this, and we've disagreed. I think the presentation we heard today, I agree with pretty much everything that's said for up to 2 days of total fasting. But when you go beyond 2 days, the published literature is to a great extent conflicting with what you read on the internet, particularly around effects on resting metabolic rate and preservation of lean body mass. And this is not my research. I learned this from people, and I met some of the people who did this in the 50s, 60s, and 70s. So George Cahill at Harvard, not that that's a great place. I got my PhD from MIT, other side of the river. And Ernst Rennick at the University of California, John Warren at Karolinska in Sweden. But what they demonstrated is after 2 or 3 days of total fasting, you get through the initial phase of catecholamine-driven response, where metabolic rate actually does go up. And there's no loss of lean mass based on measuring the body's excretion of protein breakdown products. But by day 3, protein breakdown products in the urine start coming out, and I've done studies where we've done this with the ketogenic diet to help determine what is the protein requirement to maintain lean body mass when you're a ketogenic diet. And people who I spoke with yesterday in the breakout room, we discussed the fact that the recommended dietary allowance in the U.S. is 0.8 grams per kilogram of reference body weight. For the ketogenic diet, you need 1.5 grams per kilo. We did that by measuring nitrogen balance, protein in, breakdown products coming out. How do you maintain or improve lean body mass? And that's the amount one needs with a ketogenic diet. When you feed no protein and no calories, by the 4th or 5th day, the average otherwise healthy person is losing something on the order of 3/4 of a pound of lean body mass per day. And when you get out to a month, it's a 1/4 pound still. And studies have been done, but not just on whether a person stays alive, but what happens to strength and function. And for instance, hand grip strength goes down at a month measurably when you do that. And resting metabolism starts going down. At the end of the first week, it's down about 10%. And at the end of a month, it's down over 20%. And what nobody has studied that I know of is when you finish a fast for a month and resting metabolism is significantly decreased, how long or to what degree over the next months does that come back up to or above previous baseline? The data's, I don't know if the data's there. If it's there, I would love to read it. But in the meantime, I think we need to be cautious about long-term total fasting. I have absolutely no problem with time-restricted feeding. I have no problem with total fasting up to a couple days. All those changes can be recovered within a subsequent week without any apparent illness. So.
What do you make of the differences between patients? So let's take a 65-year-old woman who is already low in muscle mass. Let's contrast that perhaps with someone with a terminal brain cancer. Do you consider things differently there?
Well, if somebody has a terminal brain cancer and their life expectancy is measured in a matter of a couple months, total fasting may extend their lives. And I have no problem with that. But it really has to be on a very carefully assessed risk-benefit ratio. It's a well-established fact that for people my age, I'm over 50.
Really?
That protein requirement to maintain lean body mass is increased relative to the basic relative or recommended dietary allowances. It turns out that when you refeed somebody who has lost a lot of lean body mass, and the thing that really kindled my interest in nutrition when I was in medical school and then in my internal medicine training was seeing patients who, to me, were clearly malnourished. And this was in the days before we had tube feeding and total parenteral nutrition. And I could see patients that I was caring for, and we were doing the best we could to reverse their disease, whatever it was. But they were dying of malnutrition. And so the idea that we could actually put a feeding tube in them or put an intravenous line, subclavian line, and give them total parenteral nutrition, that is all their nutrients as glucose, fat, and amino acids, was revolutionary. And when we had severely malnourished patients and we plugged them into this feeding, the fastest we could get them to gain lean tissue was 2 to 4 ounces of lean body mass per day. But if they're totally fasting, and even if they're long-term fasting adapted, they're losing at least 4 ounces of lean body mass per day. So the recovery time is always longer than the maximum rate of loss, which is why I say if you fast for 2 days, if it's going to take you 5 days of eating a good real food diet to get that back.
You and Jeff Volek have talked a lot about a well-formulated ketogenic diet as a term. And for a long time that was talked about adequate protein. And I feel like the field's moved to considering that higher amounts of protein are a thing. And you talked about that now. Where are we at with that?
Again, this doesn't lend itself to a simple, I'm right, somebody else is wrong. For instance, in order to optimally use protein that you're eating, you have to have adequate mineral nutriture concurrent with that. And when I was on the faculty at the University of Minnesota for 5 years, and I was the Department of Nutrition where I had my main location.
Ansel Keys territory.
Oh, he was on the other side, he was over on the St. Paul or the Minneapolis campus. I wasn't St. But I actually did meet him a couple times. And he was aware in his 80s that he'd done something that got out of control. And he couldn't turn it back. But anyway, cutting back to this issue of minerals, the Minnesota, they're really big into raising meat. And one of the things that they taught people, and I learned kind of through my associations with people, is if you're feeding chickens and everything in your chicken feed is just right, but they're only getting 80% or 70% of the potassium need that they get, you're going to go broke because your chickens won't grow fast enough, and it's going to cost you more to get to a market weight than you can get by selling the chicken. So intracellular minerals like potassium and magnesium and phosphorus are extremely important to be contained, and there are lots of examples of ketogenic diets where people have given particularly protein isolates. So again, vegetable protein isolates, I mean, they're great, but make sure they have the potassium, phosphorus, and magnesium with them. Otherwise, it's not well formulated, and it's not going to work well, and people can eat everything right and lose lean body mass. And then the most obvious one is salt, which I'm known to be really grumpy about, that if you are sodium restricted, then your body is going to waste potassium, that the renin-aldosterone system in the adrenal and between the adrenal and the kidney will, if you don't have enough sodium, the body has to retain sodium in any way it can to maintain circulatory volume. And in so doing, it'll sacrifice potassium. And so these are all, again, we get around to balance and so a well-formulated ketogenic diet is not just about macronutrients, but also the other associated requirements that need to be in balance for this to work well. And the best way to do that is don't eat anything that has more than 5 ingredients, and hopefully was still attached to roots or was still breathing less than 5 days ago.
Steve, let's change tack a little bit. You mentioned Virta Health before and Sarah and so on. I'm just curious as to where Virta Health is at now. It's been going now 5, 6 years, 7?
Founded in 2014.
14, yeah, 8 years. Well,
8 years.
Yeah. I mean, where
I
is
got all this gray hair.
Where is it at? And what do you think has it achieved its aim? And where is it going in the future?
I have to be very careful what I say, because I say, in all honesty, I'm a recovering academic. as an academic, you always basically told the whole truth, nothing but the truth, and never restricted. When you're in business and as a recovering academic, you have to be careful. So we are poised as a company now to, the people around us are probably right in assuming that we're hoping to go public, become a publicly traded company. We have many tens of thousands of patients who we've enrolled and in treatment. The amazing thing about this is that almost all of our patients, we allow them to opt out from having their data, de-identified data, included in our registry. So we now are building a data registry that is going to be an amazing compilation of data from which we can increasingly make our treatments patient-specific. But one of the things we got from our registry that was reported at the American Diabetes Association meeting is that we tracked for the last 3 years all of the patients in our treatment cohort who developed COVID. And when they told us they developed COVID, then we asked them to tell us if they were hospitalized. We asked them to have them, if they or their families would tell us if they required intensive care treatment. And we track mortality. And we did lose, I think, less than 10 patients out of like 1,400 of our patients who developed COVID. And most of these people had diabetes, which meant their prognosis was worse than average. And we had a modest number who were in the intensive care unit, but most of those 1,400 did not require any form of acute medical care. So we either have a truly remarkable group of people who, somebody's looking after them, or nutritional ketosis and reducing inflammation suppresses this thing called the cytokine storm. Anyway, I'm getting away from where we are. I think it has a remarkable future. But I'm also, at this point, since this gets into, how do you build a business? How do you have adequate profit margins to grow? How do you keep your investors satisfied? How do you keep the trolls on the internet, at bay? That's something I'm not eager to be involved in. So.
What do you? I don't imagine you. When I first met you, I don't think you were thinking I'll be involved in Silicon Valley startups and the business that has been this. What have you learnt that's interesting, and what are you happy to see behind you now?
Well, the first thing is people ask me how to get involved. I said Jeff Volek and I were kidnapped by Sami Inkinen. No, he came to us and said, this is great. You've written a book. We were actually writing another book of how to do it, which became our patient treatment manual. And we plan to put this together and franchise it to medical practices and train those physicians and their staff how to do it. But our experience before we met Sarah Hope for a year trying to work with medical practices just to do a study convinced us that we had to do this whole hog. So we arranged for our own medical practice group. We learned to do virtual medical care, and we had 3 years of practice at virtual medical care before it became a necessity with COVID. What have I learned? Chance benefits a prepared mind, so maybe my mind was prepared, but I was not prepared for it to go like this, and I'm just thrilled to be here.
Are you prepared to answer the second part of it? What are you prepared to leave? What are you happy to see behind you now?
Pioneers define new territory. Yep. Settlers build fences and roads and have laws and things like that. And I'm much more of the mindset of, don't ask permission, ask forgiveness. And that Jeff Volek and I have outside funding now to expand, much more funding we've ever had to expand our research. And we are going to go into depression, congestive heart failure, diabetic kidney disease, and potentially non-diabetic kidney disease as our next targets. And that's what I want to do. And that's having Virta in the rearview mirror allows me the freedom to do that. And maybe write another book.
Steve, you mentioned the C word, COVID. Thoughts on long COVID and the role of nutritional ketosis and your experience with that?
We haven't focused on the level of acuity to track that. We have lots of anecdotes, but anecdotes are good for forming hypotheses. It appears from what our patients tell us that they have a much lower incidence of long COVID. I mean, I was reading in the New York Times yesterday that there's a study done in, Northern Europe somewhere where I think it was maybe Sweden, where they tracked
Norway and Sweden.
Yeah, where 50% of the people who had gotten diagnosed with COVID still had some symptoms at 6 months, and it was 10% had no improvement from the full severity of their disease. Our experience seems to be less than that, but that is always colored by bias, and I'm biased. I have a significant financial stake in this company, so don't believe anything I say until we publish it in the peer-reviewed literature.
The role of inflammation in long COVID, I mean, do you think that's the key factor in it?
I think that's a key driver, but what's driving that inflammation? Is it residual virus, in cells, or what is it that the body can't get rid of that allows it to turn the thermostat back down on inflammation to get back to the point where they don't have the fatigue, they don't have the muscle aches and pains, and they don't have the brain fog. And by the way, brain fog is probably membrane damage to DHA in your brain from reactive oxygen species.
A little change of tack. I was curious through that talk because you talked about exogenous ketones a number of times. Do they have any practical use in metabolic health?
At this point, no. But it's in the public domain because whenever you do a research study that you intend to publish, you have to publish or post your protocol on clinicaltrials.gov. And if you go look there, you'll find that Jeff Volek and some very interesting people who wear uniforms are studying head trauma in people who are training to be basically doing parachute training. And in Army Ranger parachute training, about 10% of the people in that 1 week where they do night jumps, 10% of them have serious head strikes. And you might guess that one could do a randomized trial of giving somebody something to chug before they jump out of the door of a perfectly good airplane. And if they chug placebo versus ketones, you might have an opportunity to look and see what happens to head strike and concussion.
Yeah, and often, you might say a ketogenic diet might be a good intervention and these sorts of things. Because I can think about this with football players, hockey players, rugby players, and these sorts of things as well, that it has potential to be an intervention post-trauma even. Is that a thing?
Well, you mean contact sports?
Yeah.
Which are really, they're collision sports, not contact sports. Yeah.
Yeah.
Mm-hmm.
Yeah. It's just an interesting thing. And what about people who have no chance of changing their diet, but it's still going to stimulate some metabolic changes or gene transcription? Is there any role there, or is that just they should just go ahead and change their diet?
Yeah. And what's the time course? Do you have to take it before, or somebody who's has a traumatic brain injury and is brought to the emergency room? Should we plug them into an IV with 4% beta-hydroxybutyrate rather than 5% dextrose? That's a rhetorical question.
Yeah.
Because it's possible to do that, but we're not going to just start it and do it. We have to study it, and there has to be the will to look at the data in an objective way. But I think that there's a significant future for this in acute care medicine because CRP does not go down in the first 3 months, but a bunch of the other keys on the keyboard, the amplitude is markedly reduced very promptly.
So when you say not at this point, you go, it has potential. It's not evidence of absence, it's absence of evidence.
Yeah. I mean, to give an intravenous, to do a study to validate intravenous ketones as a intervention tool You would have to get an investigational new drug number. You would have to go through this whole process, and you're talking more than $100 million.
Yeah, in other words,
in the U.S., you could probably do it in
New Zealand.
New Zealand at a quarter of that price, because you're much more efficient than we are, and we have less bureau.
That'd be 100 million New Zealand dollars, a quarter of it. So that
I'll invest in that.
Now, I'm pleased to say I don't have much in common with Professor Schofield, but one of the things we do have in common is his interest in sport and performance, elite performance. And I'm interested, Steve, in your thoughts, your current thoughts on the role of the ketogenic diet in elite performance. And different types of elite performance. And I know you wrote the book about it, 10 years ago, that we've all used as a Bible. But current sort of thoughts, because it's the ketogenic diet's becoming quite popular in ultra endurance sports, but there's still a lot of skepticism in more intense sports and in team sports, ball sports, and so on, about the use of the diet. What are your thoughts and experiences on that?
A couple things. One is, the use of these is out in front of the public data, or getting out way in front of published data. That doesn't mean that those experiences aren't valid, but it means that we have to be careful about generalizability, because clearly some individuals respond very differently than other individuals attempting the same thing. So if you have a person who's done extremely well on a ketogenic diet, and they say to everyone else on their team, hey, it worked for me, you do it too, it probably isn't going to be universally beneficial or effective. The other problem we have is if somebody has figured out something that works uniquely well for them, and you ask them, how come you're winning all these events, and they're professional and they're getting paid to do that, they're not going to tell you, and we can't ask them that. I mean, there is a skier named Lindsey Vonn who dominated women's downhill skiing. All three, downhill, giant slalom, for 7 or 8 years. In the last 4 years, she was essentially full keto. But why would she tell anybody? I mean, and for the reason she said she did it, she didn't need to lose weight. She didn't need it for endurance, because she says if my event lasted longer than 2 minutes, I'd lose. Yeah. But apparently, and again, I have heard this is all secondary information, but I have heard that the reason is that her volume of training could be doubled without becoming stale and going off peak, and her training, her season would last for 8 months, from the earliest snowfall in the Alps to wherever. And she had to maintain high volume training throughout that to maintain peak. And she said, I could just out-train my competitors because my recovery time was so much better.
What do you make of a slightly adapted approach of, say, talking about a ketogenic diet, and more talking about a fat-adapted, metabolically flexible athlete, right fuel, right time?
Right. So you're talking train low and compete high.
So that's one way of doing it, or you do fasted long, easy sessions, and then you may add some carbohydrate for a specific high intensity thing, and then for a race you might change it again.
Sure. And again, the ultra runners that we have studied tell us that they train low. They may or may not eat some high glycemic, slowly digested carbs the night before, and then they will oftentimes use strategic carbs in race. Any event lasting longer than 3 hours, that individuals will oftentimes use some form of carbs where they're providing. Typically, what they evolve to is about 10% of their total energy expenditure coming in as carbs during the event. And when we look at what ultra marathoners burn when we put them on and these are people who are trained to run 100-kilometer, 100-mile distances, and we put them on a treadmill at race pace for 3 hours, they end up running a marathon on a treadmill, in a basement room in the lab, staring at a blank wall. I mean, talk about masochism. But what they tell us, what we measure is that they're burning 90% fat for that whole 3 hours, and that the 10% being burned as carbs would be the amount that they have figured out just from their own instincts that they need to take, and if they're going to do an event longer than 3 hours.
Yeah, so that's pretty consistent with the athletes I train. So they might burn 1,200 calories an hour at their long distance race pace, and they might be taking, 25, 30 grams of carbohydrate an hour, 120 calories. It's about what you're thinking, right? And that would be very different than the carb heavy athletes who might be chucking down 100 or 120 grams of carbohydrate an hour.
Yeah. Is that your experience, Peter? Because I'm sure you know as much or more about this than I do, because you're much closer to these people than I am.
I agree. I mean, it's huge individual variation. I have elite. I look after elite AFL football teams, and I have individuals who are completely ketogenic, who are absolutely fine. I have others who struggle with, who are train low, compete high, so they'll be ketogenic during the week or low carb, and then top up on their heavy training days and so on. So very, very varied. And I don't know it's just experience. I think you just trial and error. Really, you've got to try out these things. So, but we had at the. I don't know, for those of you who don't follow AFL, last year I was involved with the Melbourne Football Club, who won their first premiership for 57 years. And the main reason was that we had a perfectly balanced forward line. We had a vegan and a carnivore.
And they fought over the ball.
Who was better?
They're both pretty good. Well, we shouldn't hog all the questions, Professor. Is it? Would anyone else?
For the last 10 minutes of this, let's just turn it over, and you can just go to those either end and say who you are. And now's your opportunity, folks.
Hi, Dr. Phinney. First of all, thank you for all your wonderful work. Just a really quick question. What would be your recommendations for someone who has the ApoE4 gene who wants to do keto? Do they need to approach, or I'm probably saying that in the wrong way, ApoE4 gene, do they have to approach keto in a different way in terms of the fats, or what would be your advice?
ApoE4, and I suppose those lean metabolic hyperresponders is probably those questions. Is keto still suitable?
The hyperresponders, which by the way was the stimulus for Dr. Harburg to approach me in the gentle way she did the first time we met. That's an extremely important question. There are individuals, many of them are lean and athletic, who have dramatic elevations in their calculated and actual measured LDL cholesterol. There is a kind of a grassroots scientific project underway led by an engineer, not a physician, named David Feldman, who did a GoFundMe incentive or initiative and raised a couple $100,000, and they're recruiting. And I think they probably at this point almost finished recruiting 100 hyper responders who they bring to a research center in Los Angeles for careful testing, including not just a coronary artery calcium score, but also angiographic CT angiography, where you can look not just at calcified lesions, but coronary strictures before they're calcified. And they've looked at these people initially, and then they're going to look at them after one further year. All these people have been on a ketogenic diet for longer than a year. And when they looked at the coronary calcium scores, they were remarkably low for, not zero in everybody, but they were remarkably low for people with, if they'd had this degree of dyslipidemia long term. But and they're actually measuring ApoE and genetic predispositions. But I haven't seen the data on this, and it'll probably be probably a little over a year before we see the full data set at 1 year presented in a meeting.
That specific ApoE4 gene, would you be happy to prescribe a ketogenic diet to someone with that, or would you be concerned? Dr. Phinney's, as a patient, they turn up. What are you saying?
I'm an internist, not a surgeon. I am concerned with that.
Yeah.
But it doesn't mean that again, people vote with their mouths, but I can't forbid someone to do something like that. But we have to be very cautious, because anything bad that happens to someone, whether we caused it or not, if they're on a ketogenic diet, we're likely to get blamed. And so we have to be, as an internal medicine doctor, I tend to be cautious. But then you wonder, why did I do any of this to begin with if I'm that cautious? Because it's data driven, and we need to collect the data and then do a prospective study. And it appears to me that the extreme difficulty at getting credible funding to do this type of research, that the barrier to that is being lowered, is going down, and I would hope that we will have hundreds of credible scientists working doing objective research in this field within the next 5 years.
Charlie Bloomer, I'm a retired health statistician who's worked in the area of diabetes epidemiology for a couple of years. I'm aware that the warnings that the epidemic of type 2 diabetes is bankrupting economies around the world or heading in that direction. I'd note the Virta Studies association with venture capitalism, but I'm interested in the interest of the insurance industry in North America in the results of Virta study and how that might impact on reducing health expenditure.
That's a good question. Our business model has been not to sell this primarily to the individual consumer to who would pay out of pocket. Our business model has been to sell this to self-insured employers and insurance companies. And the reason we picked type 2 diabetes and patients, and in our study with Dr. Hallberg, picked people who had established diabetes on multiple medications, is that's where the money is. And what we do is we enroll patients in our treatment with the promise of getting paid when we achieve therapeutic success markers. So we get paid for success. If we lower hemoglobin A1C, if they reduce weight, and particularly to the extent to which we de-prescribe expensive medicines, that gets us paid. So that has attracted the attention of insurance companies, and we are aware that some of them are looking very closely at us, as in stalking. Not in a bad way, but we want to go public. We don't want to get acquired.
Yeah, that seems unfair, though, right? It's like, imagine another provider giving out chemotherapy for free, but only getting paid if the patient doesn't die. You know, like no cancer oncology group's going to do that, are they?
But we have a higher success rate than they do. No, really, this, and this is not my idea. This Sami Inkinen he's a Finnish-trained nuclear engineer who was working at one of the Finnish nuclear reactor power stations as a safety officer, and sat around for 3 years and was just totally bored because, as he says, nothing exciting happened.
That's the same job Homer Simpson had, right?
Exactly. And I think Homer Simpson generated a lot more income for, but Sami is a brilliant visionary, and so this came from him. I wouldn't have thought of doing it this way, but it clearly got us in the door. And once people see that their patients, who they assumed couldn't stick to a diet for even 6 months, that they see that we're getting the success, that's increased our access. But the door is opening, wider. So this doesn't mean we'll do it this way for the foreseeable future, but certainly for the next few years, this is certainly working for us because we have such a powerful tool that And there's another little soundbite. It doesn't have, it has some side effects, but what it has are really potent side efficacies. That asthma gets better, joint pain, swelling gets better, polycystic ovary gets better, syndrome gets better. We actually have a registry. We tell women of childbearing years who join Virta, we don't know the effects of this on a fetus, so we urge you not to get pregnant when you're on the ketogenic diet. Pregnancies happen. We have quite a long list of Virta babies that we're not studying, but these are the things that the side benefits that excite people about what we're doing and about the potential of expanding this to a broader reach.
Depression? I mean, I'm just saying that's a massive cost to economies, right? People being depressed, so that's another potent side effect.
There is a foundation that's been funded in the U.S. by a couple very wealthy families who have family members who've been severely affected by depression. And it's in the public domain, and I think they've committed something on the order of $30 million in the near future to study the relationship between well-formulated ketogenic diets and potentially exogenous ketones and depression and bipolar disorder. So yes, coming soon to a meeting near you.
Just to conclude, I should let you in on a little secret. Sammy Inkinen actually came out to Australia to look at the possibility of setting up Virta Health in Australia, and I was fortunate enough to be invited to lunch in Sydney. I don't go to Sydney for lunch for too many people, but I figured Sammy Inkinen I'd go for. Very nice lunch, Cafe Sydney. I could recommend it. Very nice. But ultimately, he decided that the insurance structure and so on was so different from the US situation that he couldn't really see how he could make it work in this country. But maybe it's time to revisit that. But anyway, we've got the wind up from the big boss back there. So on your behalf, I'd like to thank Steve Phinney for a fantastic.